Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by funding from a grant from the Rosalie and Sherry Exline Ziegler Fund. And tonight, we've got a colleague of mine and a friend of mine, Dr. Mirnes Kadic. Welcome, Mirnes.
Thank you so much. Pleasure to be here.
So we're going to talk about osteopathic manipulative treatments, OMT, or sometimes called osteopathic manipulative medicine, OMM. And Dr. Kadic is a doctor of osteopathic medicine, a DO, and we're going to learn what is this technique, OMM, OMT, and how can it be a benefit in cancer care?
Absolutely. So we initially receive our training in medical school and osteopathic medical schools, which are growing every year here in the United States. You continue to immediately place your hands on patients, which are your colleagues and your fellow classmates at that time, and learn to utilize certain philosophies associated with the anatomy and the physiology of the human body, as well as how there can be abnormalities related to that, and to correct that with the use of your own hands, using your medical background.
So let's learn a little bit about you. Where did you grow
up? I'm originally from Bosnia, and I grew up in Germany for a few years. Having been an immigrant from Bosnia myself, we immigrated to the States initially.
And how old were you when you came to the United States?
I was 7 years old.
And so at 7, how many languages did you speak?
At that time, 3 languages, yeah.
So Bosnian and German and English.
Yeah. So German has fallen away by the wayside a little bit, and then continued my time in Nebraska, and then Iowa became home after some time.
So high school in Iowa.
High school, we finished at Valley High School. I went to Mercy College of Health Sciences.
Gotcha.
Got my bachelor's of health sciences there.
And then where'd you go to medical school?
Went to Arizona. So I received my bachelor's in biomedical science. Master's of biomedical science, and my DO degree at the Midwestern University in Glendale, Arizona. But just prior to that, I was a nurse's aide at Mercy for 5 years, just before receiving my doctorate degree.
Yeah. And so for people who don't know, there's generally speaking in the United States, 2 different types of medical schools.
Yes.
MD program. So I'm an MD. I went to medical school at Creighton. University of Iowa is an MD program. And then the DO programs are osteopathic.
Correct.
And so in Iowa, DMU here in Des Moines, I think is the only osteopathic medical school in Iowa.
And it was one of the first 5.
First 5 in the country. So going back to just the beginning of osteopathic medicine, what distinguishes osteopathic medicine from, I guess we call it allopathic?
Yes. Actually, it was created and developed by Andrew Taylor Still, who is an MD. And the philosophy was that we're looking at the global picture of a human body, everything that's related to that. And at root, it was started with the anatomy itself and looking at the musculoskeletal system. And similar in the chiropractic realm, deep tissue massage, looking at how we can look at areas of restriction, allow the body to use its natural properties to heal itself, utilizing the lymphatic system and the immune system. And subsequent therapies developed from there, first starting with the musculoskeletal system. Then we do have manipulations on the viscera, the organs, and then kind of separating that between the age groups and different areas specific to that. And so what defines us a little bit differently is just the initial philosophy that they have coined the term holistic. But really, the education is founded within similar in terms of our regular sciences, but then also ingraining within us the ability to get comfortable with touching a patient, being a patient yourself, using your hands as kind of another sense to the rest of your evaluation and assessment of a patient, but also then implementing that in your therapies in particular.
And do you think different osteopathic, obviously you only went to one osteopathic medical school, but do you think different osteopathic medical schools have a different priority in terms of how much emphasis they put on OMM as opposed to And I'm just going to tell you my impression. I know many doctors of osteopathic medicine who practice pretty much indistinguishably from an MD.
Yes.
And it seems like many of them don't embrace or actually keep up with the skills of OMM. And I wonder, is that somewhat related to how much emphasis there is in school? Or
I think ultimately it's more about first, it's what specialty did they pursue a residency and fellowship training in. Secondly, it'll be how much further passion and interest do they have that, even if they are just in the primary care realm, which includes internal medicine, family medicine, pediatrics, and OB-GYN. And at the end of the day, it's then their final decision of whether they're going to be implementing those similar sets of skills and therapies for those patients. They've all at baseline had the same standard curriculum, same standard training, and examinations to pass and receive their osteopathic degree. And so the education in itself, from school to school, from which I've seen even as a resident and chief resident interviewing applicants, there is very much a standardization to the curriculum, having looked at those schools myself as well, having interviewed at many myself. So I believe that is pretty standard. It's what comes after that will separate some of those individuals in different paths.
Gotcha. So you graduated from medical school in Arizona,
Mhm.
and then you did a residency in family medicine. Is that correct?
Yes, and that was in Los Angeles,
In
California.
California. And the residency that you were in, was it primarily DOs, or was it a mixture of MDs and DOs?
Subsequently, a mixture. When I started, so what we have now is called the ACGME, and at one point it was ACGME and the AOA, which was the DO programs.
So the
They've all
DOs and the
merged.
MDs had separate
Yes.
training programs after medical
Correct.
school.
That did not stop you from applying to those.
Mhm.
However, they were preferential to the applicable degree. Now it's all combined. And so it's all under one umbrella called the ACGME. However, this program was mostly MDs. And so while there was one DO, one of my seniors, I was one of the only ones for a while.
Then, so since you were doing your residency in family medicine in a program that was primarily MDs,
Mhm.
How did you keep up on DO skills, and how did you advance your DO skills during your residency?
All it takes is to have enough practicing osteopathic physicians that are still using and applying that to have as faculty, which we did have. And then they will ask you if you have preference and whether you'd want to continue those skills, which I always, from my day one, it was one of my criteria, regardless of the type of program, whether they were initially before the merger, mostly osteopathic or allopathic. And so as a primary care physician, I wanted to continue to offer that. And so having had several physicians as mentors, I continue to maintain those skills and further those skills, and subsequently then teaching that as well to the subsequent interns and fellow residents once I was a chief resident.
So back to your training in medical school, where you
Mhm.
first were exposed to OMM, and as you mentioned, that the practice as you're a medical student, it's often on your fellow students, and so
Yeah.
you serve as a patient, if you will, for your fellow students, and they serve as your patient.
Mhm.
What was that experience like, and how did you come to realize, either through being treated yourself or treating your buddies and colleagues, the value of OMM?
Yeah. While we have much younger cohort, you do get to appreciate different body sizes, habitus, simply respecting another gender based on your touch. And some of these are nonverbal cues and the ways we approach a patient, first and foremost. Secondly, it would be you will see some pathology, but it was always to get a good foundation of what is normal, understanding to complement that with your dissection anatomy labs and everything else that you would learn together to understand what is normal and what is abnormal. And then because a lot of us deal with simply neck and back pain from also being students, having had that treatment received myself, and how it impacted our longevity, our day-to-day stamina, our regular physical activity, and also understanding the ergonomics of how we are approaching a patient when we're treating them, but to maintain our back and our mechanics as well. So there's a lot of overlap with the physical therapy realm and the chiropractic realm in that regard as well. And so you get to see both sides of the treatments in particular.
And maybe give us an example
Sure.
in training or during residency of a patient, so not another student, in
Yeah.
which you sort of, the light went on that you knew you were doing something that was really providing great benefit.
Sure. We have several where I think one of the most common things that we see in primary care is back pain. And a lot of it is mechanical back pain, meaning we're dealing with muscle spasm, misalignment. Sometimes it's a leg length discrepancy, a tilted hip or pelvis, and how it'll also even stem possibly from scoliosis and such, where I've had several patients who they would like to minimize medications if possible. They'd like to complement it with other therapies such as physical therapy and stretches. And the first and foremost goal is to assess their goals of care and their level of function and what is going to be satisfactory and what are we going to do to get you to that point. So we see several patients where we can realign some of the misalignment, focus on tight muscle that can be softened up and get areas of restriction to be more mobile. And with that, then the body starts to heal itself and you start to become more functional and more mobile. And it then will essentially have more muscle memory and won't want to rebound into those other maladaptive positions. Some of that is also ergonomics and addressing that, whether it be a full-time desk job, whether it be a very laborious occupation that requires a lot of heavy lifting and the mechanics that come around that, and possibly addressing poor techniques, if you will. And in particular, most recently, one of our mutual patients that we've recently discussed as well, who've also had surgeries that at times or radiation that'll cause fibrosis or restriction in the chest or different areas where we can get things to move and open up, where your breathing is a bit better, your lymphatic and vascular flow is a bit more improved. And if you're dealing with swelling, we can improve some of that swelling as well, just because the system and the circulatory system is functional, more optimal, rather.
So we're going to start talking about some of the roles of OMT, osteopathic manipulative treatment, in cancer patients. So Dr. Kadic is a couple days a month. It has a clinic at the MercyOne Richard Deming Cancer Center and helps our cancer patients. Before we do that, though, let's talk a little bit about compare and contrast chiropractic medicine with osteopathic medicine. You know, they're both hands-on, and it's understandable that sometimes the public doesn't understand what's what and what's the difference. So how would you distinguish, compare, and contrast chiropractic theory and treatment with osteopathic treatment?
First, similarities would include assessing the skeletal system and the bones, which are similar. That would be with our hands and palpation, also imaging using x-rays, and assessing those needs. I also am able and have been trained in the articulatory techniques, which is the cracking and popping, if you will, to get a quick adjustment and a segment to be realigned anatomically. There is variety I've seen also in chiropractic services between adult and pediatrics as well, where some will focus a little bit more on the soft tissue or muscle, ligaments, tendon. That tends to be where we are mostly focused. We also have trained in terms of also manipulating certain organs or viscera, lymphatic system, and dealing with swelling and lymphedema. as well as addressing chronic headaches and migraines, and chronic neck pain and back pain, in particular. And the biggest difference is I treat a patient solely with my hands. I use no instrumentation at all. And in chiropractic offices, you may see certain straps or Y straps being used, oscillatory percussion guns, vibrating guns to help with massage and relaxation in those regards. Depending on the chiropractor, you may see some physical therapy treatments such as heat, or I've seen biofreeze, which is over the counter, which they'll use in their treatment on the patient with medications, which I do not do.
So yours is exclusively
all hands-on.
hands. So sometimes when I'm explaining to my patients the services we have, so we also have chiropractic services at the cancer center. And so let me tell you what I tell my patients, and you tell me if you think that this is correct. I said that the chiropractor often will focus on skeletal alignment, and the osteopath will often focus on soft tissue and fascia and the sort of the connections of the muscles and the
and how they could potentially affect the circulatory system, including the lymphatic system. And albeit I will always assess the skeletal system since it's all connected for me. So I address multiple facets.
Okay.
Yeah.
So as I mentioned, we've got Dr. Kadic is one of our osteopathic physicians that provides osteopathic treatment in the cancer center. And we also have in the cancer center a chiropractic treatment, physical therapy, massage therapy, and acupuncture. So we kind of embrace all of those integrative techniques as part of a holistic approach. So we have shared many patients, and maybe let's talk about the role of OMT in treating cancer patients. And I would say most of the time we're talking about patients that are having some issues, not so much from their cancer, but from their cancer treatment. So sometimes patients might have, significant issues, let's say pain in the spine from cancer in the spine, or they might have issues related to, a sarcoma that's causing dysfunction. But many times we're talking about patients that have been through cancer treatment and have had radiation and chemotherapy to the throat, or surgery and radiation to the breast or the chest wall, or they've had a sarcoma, a large tumor of their leg, and they've had surgery and radiation. Maybe let's use 3 different examples. Let's start off with a patient who has completed breast treatment, and the breast treatment, cancer treatment, included chemotherapy, bilateral mastectomy, radiation, and ongoing hormone therapy. And they're now cancer-free, but having lingering issues such as pain and restricted movement and stiffness of the soft tissue from the radiation. How would you do your assessment? And in general, what would be some of the techniques you would use to help a patient like that?
Absolutely. My assessment starts as soon as I grab you from the waiting room and start walking down the hall with you. I assess your posture. I assess if there's any, if we're in more of a protracted state, if we're able to stand up nice and tall, if there's any obvious deformity or curvature of the spine, or if there's any, even when you're walking, I can assess the lengths of your arms to see if there's any imbalance in your shoulders. So starting even from the neck down. And at times patients may even be tilted in their neck. And these are subtle cues that I just, from observation alone, before I'm able to see them in the room directly.
And it's interesting because many patients are not used to the physician coming out to the waiting room and walking them down the hallway to the room.
And there's a bit of mix now, since I also have my own nurse that will from time to time join me. But the majority
there's a
of
lot
the time,
you can gain from that.
Absolutely.
30-foot walk with them.
And especially when assessing the lower back, the pelvis, as you've mentioned some of the other examples, but we'll stick with the breast cancer example for now, is also just seeing if there is a noticeable abnormal gait cycle. And So that's starting with just the big picture. In terms of this, I always at least address a segment above and a segment below. And if there's other additional areas
And
that
describe what you mean by a
yes, so
segment above
if
and a
let's say
segment
we're
below.
dealing with a chest, breast cancer patient, different surgeries, radiation to that area, I definitely will start with the neck and at the base of the skull and go to my lower back, at least the mid back. All of that will be connected, and then also addressing the rib cage and different ribs, and if there's any that are stuck in certain positions, if there's any asymmetry in that regard, if there's any swelling or restriction in all of the muscle that attach to the chest, your different pectoralis muscles, the shoulder, the neck, the upper back, lower back. And there's several different muscle layers that we have to get through. The fascia, if the shoulder is also being affected. And so we try to address all of those components. We try to see if there's any additional arm swelling that's on one side or the other to address any sort of edema or lymphedema from those surgeries and procedures. And so I'll usually just sit and listen first and foremost and see what the patient from their own experience has been dealing with so far, using your notes as well to put those two together, looking at the imaging as well. And then I tend to explain to patients that my MD brain focuses on things first, meaning I've looked at the imaging in areas that I've ruled out certain techniques I should not be using. For example, this example that you've used is a patient who is in remission, but if not, if they've had any ongoing bone cancer or metastatic lesions to the bone, I absolutely, majority of the time, I don't do any cracking techniques. And those are one big obvious contraindication for a patient who I would never want to hurt a patient or induce a fracture. And so we absolutely avoid that. And then in complementing that with their goals of care and what they've been experiencing, and then follows the exam. And I'll go through all of those areas from light sensation to deep palpation and assess areas that need to be improved. And we'll discuss the treatments that we'll be doing today. And we easily flow into that and go right into it.
And one of the great things about having you in the cancer center, is this is truly integrated, because whether you're seeing the patient or the chiropractor or the physical therapist or the massage therapist, the acupuncture, we go over what is the state of the cancer. Is this somebody who has stage 4 metastatic cancer and it's the cancer causing the symptoms, or is it someone who's cancer free? But has issues related to the cancer treatment, and what sort of surgeries did they have? Did they have a lumpectomy or a mastectomy? Did they have breast conservation? A nipple sparing, skin sparing? What sort of implants do they have? What sort of restrictions do they have? So the fact that they're being seen in the cancer center and all of the cancer records and imaging are available to all of the touch therapies, it really is integrated.
And if there's any further plans from your team and the surgeons and the oncologists to know also when there is a role for certain therapeutic modalities, and when timing is also key of maybe holding off on certain ones and then reintroducing them later to continue to help with the patient's journey.
Yeah. So we talked about one example, and that's a fairly common example, and that's a women who've gone through breast treatment, and especially those women who've had surgery and radiation. Both of those, healing from surgery, healing from radiation, can cause a lot of scar tissue, and scar tissue can cause symptoms.
Absolutely, especially when it starts to constrict and contract. And our bodies are meant to be mobile, and we're supposed to have gentle fluid in a lot of our joints and even in between the tissues. And so at times when that is affecting the mobility of the muscle tissue and the fascia, we have to open that up a little bit. And unfortunately, it's not always an immediate fix. It's when we've dealt with months of treatment, it's going to take several sessions or even sometimes months of continuing treatment to help encourage that to heal itself.
We also have very good occupational therapists that are trained in lymphedema. And, again, people are aware that if a woman had cancer in her lymph nodes and a lot of lymph nodes removed and then radiation, lymphedema, the arm can be an issue. but I'm not sure that everyone realizes also the lymphedema that can happen in the torso.
Yes.
And the type of treatment that you can do that may complement a lymphedema therapist.
Well, even in the extremities, we have a technique called effleurage. It really just looks like a massage, but a philosophy of where we start at the end and work our way towards certain channels of the lymphatic system. But we definitely start with the opening where the heart and lungs sit, and a lot of our drainage happens into the cardiovascular heart system. And then we work our way to the arms and can focus in that area as well. We'll do the lower legs and extremities as well. And we've had several of those patients where it'll complement. And sometimes I will make the statement that it's good to have redundancy and overlap in our services so that your similar tissue that is affecting you is being addressed multiple occasions, and so we can continue to treat that area.
Okay. So let's use another example, and that would be someone who had cancer of the throat, let's say the tonsil, and typically that's treated with high doses of radiation and chemotherapy, highly effective in curing the cancer, but 6 months, a year, 2 years, 5 years down the road can be very significant firmness, stiffness, loss of flexibility of some of the neck muscles and the trapezius, in addition to dry mouth and swallowing issues and voice issues. What's your approach to someone who, again, we're talking about someone who's cancer-free but has a lot of residual late toxicity from the radiation?
Yeah. I always approach things superficial and work my way deep. First, it would be with the skin and the fascia attached to the muscle, then addressing each muscle in particular to help get mobility in that area. That'll even include all the small little minute muscles underneath that assist in the floor of the mouth. We have techniques as well that are intraoral, where we can go after the muscles that affect chewing in that sense as well, then affect the posterior neck muscles. And a lot of our salivatory glands, a lot of that, the functions of chewing and eating and swallowing are also associated with several cranial nerves, which are big nerves from the base of our brain that help with a certain function, whether it's the sensation and the taste, whether it's the function of actually chewing. And so those come through certain areas at the base of the skull, and that we can help target those areas to release and get mobility as much as possible. And of course, that's after it's left.
So you're talking about working on sort of where they come out through.
So, but you've got to go through several different muscles, in that area. And it's a lot easier, for example, even in pediatric patients where we have trouble with the latch. And when a newborn is even needing assistance with breastfeeding and even bottle feeding, where we can address the vagus nerve at the base of the skull to help with latching. So we'll work with even our lactation consultants in that regard. The same is applicable even with adults when they've had such injury or sequela of treatment, and we can try to address it at that point as well. So that would be the approach, going from all of those different systems that are connected to improve mobility, lessen restriction, if that nerve in any way is affected and stuck and restricted, to help kind of dig our way all the way deep and to help get things moving so that some of the function will improve. Globally, majority of the time, it's really the fascia that we're mostly focused on because of the fibrosis and the stuck tissue. But as you can see, we start superficial and work our way deep and see what areas that are applicable to the patient are most affected and kind of hone in that area.
So we have several patients that are sarcoma patients where they had a soft tissue tumor of the arm or the leg, and the treatment consists of radiation and surgery. And as we mentioned, both of those can cause scarring, and they can become more firm over time. Anything in particular that you want to add? Let's say patient we share who had a sarcoma on in the hamstring region that was radiation, surgery, scar tissue. How do you approach that sort of a situation?
Initially stretching, and then every muscular group is compartmentalized. And so we use that knowledge that you would also see on the imaging, but using that knowledge to slowly work within the fascia that separate each muscle.
Mhm.
And a lot of that is deep pressure, deep tissue. And at first could be a bit of a good pain and maybe a bit of a discomfort, but we start gentle. We work our way in. We assess the patient's threshold as well and try to separate. After we've done some gentle stretching, they would usually also do stretching on their own, heat therapy to help relax and get more mobility in the area. But a lot of that would be focused on getting this muscle to really stretch as far as possible, but a lot of deep tissue work. So that's where our focus would be. And in particular, I think you may be referring to a mutual patient. So depends on where their areas are also most affected, whether it's closest to the hip, the middle of the belly of the muscle, closer to the knee. Ultimately, all of that will be covered, but also then really focusing on those areas to help separate those muscles. The other philosophy is this: when you flex a bicep muscle, your tricep muscle has to relax. And so that's called reciprocal inhibition. And that's where we utilize the nervous system to our advantage. So I would work a lot in terms of engaging the quad muscles to then engage the neurologic system to cause inhibition of the hamstring muscles as much to our ability. And that simply includes having them even bent their knee, almost their heel touching their buttocks, and going in different angles and degrees of knee flexion to slowly recruit certain muscle fibers and fascia, and also use that nervous system spinal arc feedback mechanism to our advantage to help just quickly and briefly provide some relaxation. Then I can get working with my hands and provide some deep tissue treatments.
One of the unique things about the scarring that happens with radiations, it tends to get worse with time. So you might work with someone who's, a year out from radiation. It would seem to me that they probably are going to need some refresher courses or additional treatments as time goes on, because the effect on the tissue from the radiation that took place a year ago is still kind of being manifest as the late effects of the radiation kick in. So I would imagine that some of these patients end up being lifelong.
Yes.
Get benefit years and years afterwards.
Yes, and there's the varying degree in the frequency and duration of treatments, but I have several that, if you will, are on a maintenance track where they're regularly coming in, and it'll complement things that they're doing at home or other services that they're seeing.
Okay.
Yeah.
So maybe a last example would be pelvic radiation, and this could be a woman with a gynecologic malignancy of the cervix or uterus, had a hysterectomy, then had chemotherapy and pelvic radiation. And some of the things that we're seeing, and we do also have, bring it in right now, we have a pelvic floor therapist, female pelvic floor therapist that can help with this as well. But where after the surgery and the chemotherapy and the radiation, not only do they have the scarring from the surgery, the scarring from the radiation, but they might have been also thrown into instant menopause. And so you can have potentially bilateral leg edema. You can have a fibrosis of the muscles, and you can have vaginal dryness and also anatomic changes that can have significant issues related to sexual dysfunction.
Yeah.
So where would your role be in, say, a woman who's had hysterectomy, chemotherapy, radiation, scarring, lymphedema, and sexual dysfunction?
Sure. Again, we kind of start exterior, right? And looking at if there's any tilt to the pelvis, if there's any sacrum abnormality. So our pelvis is made of 3 different large bones. that create the base of the pelvis. And so we assess all of those to see if there's any misalignment. There is a lot of anatomy in that small area, and it does not take much for nerve to get impinged or a part of our circulatory system to be compressed, and to help alleviate some of that pressure. We also have treatments on the pelvic floor. These tend to get more sensitive. They're all still external. None of these are internal. And so there is no sort of penetration with these techniques. Okay. So we first start with addressing the lower back, the pelvis, and the lower extremities. The lymphatic techniques that we could even use similarly, even if they're just swelling that are not lymphedema, but same techniques will provide relief in that area as well. And again, working on getting some of that musculature to release from the pelvic floor that could be impacting some of the other organ systems or the circulatory system. That would be where most of our focus is, while being grateful for the physical therapy realm, because they've also very specific techniques that just in that one area. And then again, all of our musculoskeletal system is wrapped in fashion, and that's also another technique that we can apply in this area in particular. A lot of our referred pain will be from the nervous system, and it'll also contribute to lower leg pain and back pain. And so then we'll also focus more on the muscular system in that regard.
So I think you've been working in our clinic for about 4 months now, if I remember correctly. Are there any other particular medical situations that come to mind where you've been able to provide significant benefit to our patients?
There are times where we've also had some abdominal cancers, and they've had surgeries in those areas as well, and feel that that area is restricted and their diaphragm and their rib cage is affected in that regard. We have some gentle treatments as well to help open up the diaphragm a bit more and focus on the abdomen in that regard. Not quite yet with the patients that we've seen, but in my experience before, we've had patients who are also affected by constipation. And while they're on many different medications, we have techniques where we can help work our way into the intestines, but obviously limited. We've got a lot of muscle, a lot of tissue on top, where we can just help restriction to release, and then they're able to synchronize a little bit more from the foregut to the midgut to the hindgut, and all the systems can regulate a little bit more and get to complement the medication.
Using your hands on the abdomen,
yes,
to help
gentle pressure,
get things
just to get, and
going.
we use it also very commonly in pediatric patients, where I've had even kids in the hospital, and that's their discharge criteria, and they can't go home, and they're on multiple medications, and they call in an osteopath just to try, and we get them moving and get some relief. And so we've had several patients in that realm as well get relief and even come off of certain laxatives.
Yeah, great. I think we're going to open up to questions and answers now. So we've got a live studio audience, and we also have folks watching us live streaming. So if you're watching us live streaming, and you can just put the question in the comments box, and we've got a microphone here. Angelina, you're up first.
Yes, I do recommend this because I have experienced this and my lipedema and everything. But I have a question. You said you only do utilizing your hands. Have you also used what you call the high frequency massage gun?
I have not.
No. Okay.
I have not. And again, there's a bit of flexibility in different individuals and what techniques they're also using. But from my education, everything was always with our hands and our hands alone.
Oh. And do you also do you prescribe anything like muscle relaxers or anything like that?
Yes, just as if you were to see any physician, DO or MD. We absolutely will address and complement all of our services with medications if that's applicable and appropriate for you. In addition to making sure that we're not just being greedy and keeping it to ourselves. If you definitely benefit from evidence-based therapies, PT, one of our bestest friends. We definitely will include everyone in between.
It does help me,
Yeah.
especially when you're sleepy and you get up in the morning.
Absolutely.
Yeah.
When we're not able to be there,
Yeah.
you're going to need some additional support.
Oh, cool. Thank you.
Yeah.
Mr. Rebel Rebelski.
Hi, Doc. How you
Hey,
doing?
good. How are you, Steve?
I'm doing fine. I have a question in regards to a neuropathy.
Yeah.
Do you, as a chiropractor,
He's a DO.
DO,
doctor
I'm
of
sorry.
Osteopathic medicine.
okay, I'm
Yep.
sorry, you don't mess around with neuropathy or anything like that, correct?
So neuropathy is a big umbrella term and a complicated subject, and it depends on the type of neuropathy as well as was it a medication. Most of what we deal with, and yes, the short answer is yes, I will see you for neuropathy. Will also be if there's looking at the entire system. If there's areas where nerves are being impinged mechanically, I will work on those areas mechanically. If it's a medication, if it's diabetes, if it's radiation, a lot of that tends to be really medication focused. But yes, we can help complement that. However, a lot of the treatments, unless it's truly mechanical, to work with our hands, have some limitations to that, and that I will discuss with patients.
So
as
I
well.
think what I'm hearing you say is that if it's, say, let's say a back issue,
Yeah.
a disc issue, so impingement of the nerves in the low back that might be causing neuropathy of the legs, but the actual cause is more up in the pelvis or the back.
And it could be in the hip and the sciatic.
But that would be something you definitely can help with.
Yeah. And
But-
where the nerve kind of tracks, I will assess those areas. And if they're absolutely pressing on the nerve and causing some of that neuropathy in the area, we can focus
But if
on
somebody
that.
got a bunch of chemotherapy and their hands and feet are numb
Right.
and tingling from the chemotherapy, that's
That's-
generally not something you can.
Because essentially it's a trouble with the nerve itself and its insulation and its covering. And so it's to mechanically fix that with my hands. That's actually more of a metabolic problem. Yeah.
Okay. What's your attitude in regards to, now I have peripheral neuropathy.
And is it do you think it's from your back, spine, pelvis, or do you think it's
I
from
don't know where it came
medication?
from. I've had 2 knees, 2 hips, and 2 rods up my back, and a lot of operations. But I actually felt the neuropathy way before I started to have that. But as it progressed, it went farther and farther. Well, finally, I went to what I thought hopefully would be a person, Ole Olson, the chiropractor. And, he tested me and stuff like that and said, yeah, you're pretty well shot. You couldn't feel anything in the bottom of your feet or the side of your feet or anything like that. So he put me on a machine that where I would be electronically stimulated.
Mhm.
And, I can go on, but I think you kind of know what I'm
Yeah.
talking about.
But
And-
your neuropathy is just your legs and feet, not your arms and hands.
No, just basically in my feet up to my ankle.
Mhm.
And, so I was just wondering if you would have any information that might be able to help me. I am going to, I've got a long story, so it's something I won't share at this point in time, but I just wanted to know about the neuropathy
Yeah.
part.
And
So,
as Dr. Deming has alluded, if it's really a structural and something from the spine, from the hip, from where the nerves travel anatomically, then that's really our realm. If it's due to medications or a neurologic problem or a metabolic problem, then we do have limitations in our treatments as well. And I'm not scared to say that, and I want to make sure that you get the
Yeah.
proper care that you deserve. There are other treatments and modalities that are out there, and I think you've mentioned, probably alluding to the TENS treatments as well that they may be using, which we at times will do for chronic pain or neuropathy or even they'll even use it in urology for bladder problems. So if it's structural, where it's something from the back, then yes, that's something I can address. If it's something just in the legs, usually we have a bit of limitation to that.
And Mirnes, there would be no contraindication, no reason you couldn't work
No
on somebody
contraindication.
who's had bilateral hip replacements, bilateral knee replacements, and rods in their spine.
No.
You could still do osteopathic treatments.
Majority of the time, it's hard to find a contraindication. However, the fact that I'm also a general trained physician and put that hat on first, and I look for those things first. But majority of the time, I also have a milieu of techniques that I can either use or not use, and I say it can only help you. And most of the time, I've never hurt a patient, and so it won't hurt you. I just want to also be cognizant of your time. So I usually say we at least do 2 or 3 sessions. If after 3 sessions you've noticed nothing, I'm not going to waste your time any longer. But I'm always happy to see you.
And just to brag a bit about this cancer survivor, he also summited Mount Kilimanjaro.
Okay. Wow.
Yeah.
No big deal.
I didn't have bad neuropathy there right now.
I think you only had 3 artificial joints at the time that you did that.
Neuropathy came a little bit later on where I would start losing balance. So
Yeah.
Kilimanjaro is totally out. Go ahead, I'm sorry.
Other question here. Alice has a question.
He's a great dancer.
Yeah.
You got time for a question?
Yeah,
Yes.
totally.
Okay, since the whole body works together.
Yeah.
And a patient comes in, you have such limited time. How do you, you don't get to know the person's lifestyle and everything that has preceded and caused some of these things.
Mhm.
So isn't it difficult to try to find what's really wrong?
Yeah, but that's also the role of a physician.
That's what you do. But
That's what we train for. And at times I've even had feedback where our minds can work pretty quickly. However, you're right. It does take time to sit down and to review all of those things. And we typically will start with a consultation. Most of the time will still provide a treatment with that initial consultation. Here and there, I have had time where we just had a conversation the entire time to really understand what's been going on, where's the problem now, all of the areas that are affecting this so that we can best address it, and then really outline a therapeutic plan that we can proceed with. I myself also provide patients more time. So our consultations are 40 minutes instead of a general 20-minute visit. And so are the treatments. And so I've standardized that so far. For some patients who want something quick and they want to get in and get out and they have one focal area, we can accommodate that as well. But generally, I've found that time to be sufficient to make sure that we've gotten to the majority of what's going on. But also, yeah, it's going to take time for us to develop a relationship, for me to see you and assess your body multiple times. And at times we will even separate certain locations for treatment purposes so that we can also benefit from an area being treated that same day, so that you don't feel that it was just a discussion. So as you can see, there's a bit of flexibility there. And depending on the patient to patient, the complexity also varies as well. But with volume, with training, we get to be pretty quick. And at times, if that's the concern, I let you have a discussion with me while I'm assessing you. And so we're double backing on that. So I'm actually examining you while we're having a conversation to put everything together.
okay.
Thanks, Alice. Other questions?
Doctors, we have a question from one of our viewers on the Above and Beyond Cancer Facebook page. Andrea wants, how can OMM help with a patient that has lymphoma? That's the question.
Yeah. So let me just, as the cancer doctor here, that lymphoma is a very broad disease, and a lymphoma patient could have lymph nodes that are very large that are causing issues, or they could have just abnormal cells circulating in the bloodstream that aren't causing an impingement. So that would be hard to answer in general, I would think. But let's say a lymphoma patient who has enlarged lymph nodes that are causing some sort of discomfort or edema.
Correct. And a level of degree depending on the patient, as you've alluded to. Majority of the time it is that very last case where it's affecting other tissue in the surrounding area that we need to address. And depending on the type and location, those are the areas that we'd focus on.
Yeah.
Yeah.
And a lymphoma patient might benefit because, let's say, they got radiation and it's not the enlarged lymph nodes are gone, but you're dealing with the effects of the radiation.
Absolutely.
Or somebody has had chemotherapy and has toxicity from the chemotherapy that's causing the symptoms. So I guess, Andrea, the answer would be yes, there are some things that could be helpful, but because lymphoma can present itself in many different ways, it's hard to give you a specific answer.
Andrea says she has SLL.
Yeah, so it's not so much that the osteopathic technique would differ depending on what the name of the malignant cell is. It really is what are the symptoms of the patient. So maybe to state what I thought was obvious, but we haven't stated it, we don't pitch OMM as something that kills cancer cells
No.
and improves the cure of cancer cells. We think that OMM is something that makes the body function better, helps relieve symptoms, and is done integrated with chemotherapy and radiation.
Absolutely. Majority of this is dealing with the symptoms, dealing with the rest of the human body in terms of areas that you're having tension and aches and pains. But in terms of the foundational problem that's at hand, there are much more specific treatments which are in your realm.
Although I suppose OMM could enhance the immune system in ways that might, be.
Well, and we use it in areas of acute inflammation and the swelling that comes with that, and that type of specifics of the immune system as well, the lymphatic system, and getting things to move in terms of the circulatory system. But to say we have a technique that specifically targets one cell or something like that is not correct.
I think, Kevin, you had a question.
Yes, I did.
Oh, and Gary, go ahead first, and then Kevin.
Yeah, I was thinking, when you were talking about when you first assess a patient, the fact that, when you take that walk down, I'm curious as to, are you ever, in a public situation where, lots of people around and you see
You're making
people
diagnoses.
walking
Yes, all the time.
all the time?
All the time.
And you
It's
wish
hard
you
to turn off.
You wish you could take your card, just give it to them.
Yeah, I should.
I don't know. I think psychiatrists do that all the time.
Well, and it'd be the same as seeing a lesion or a rash or something that's just that with the naked eye you can see quickly. But yes, all the time.
Yes, do you have techniques that you can teach your patients that would promote, the flexibility in neck tendons that been restricted by radiation?
So yes, there are certain.
But you can teach those techniques.
Yes, we could teach certain. Mostly would be stretches. There are certain techniques that I even applied to myself, but I will say the success is different when you're just absolutely able to relax and someone else is doing it where it's passive. But there are certain stretches and certain mobility movements that we can absolutely discuss, and which we do all the time.
Yeah. So treating the neck for stiffness of the neck that comes after radiation therapy for head and neck cancer is definitely something that OMM can help with. Yeah. Any other questions? Well, Mirnes, Dr. Kadic, thank you so much.
Pleasure.
Thank you for all you do for our patients.
Absolutely.
Thanks for being here this evening.
You're welcome.
And if any of you out there would like to meet up with Dr. Kadic and experience an OMM treatment, we can do that at the MercyOne Richard Deming Cancer Center. Just contact us. If you know somebody that would benefit by watching this program, it's been recorded and it's going to be available on demand at the Above and Beyond Cancer YouTube channel. And it's also available on demand at the MercyOne Cancer Center website. I hope you'll come and join us again next week. Thanks, everyone.
Thank you.